All right, we're going to go ahead and get started. Good afternoon, everyone. Thank you for joining us. My name is Danae Aber. I'm the Executive Director of the Louisiana Rural Health Association. Thanks again for joining us for this webinar, Chronic Kidney Disease and Type 2 Diabetes, Early Diagnosis and Treatment. LRHA is happy to host this webinar presented by Dr. John Mayers. This webinar is being recorded and will be available along with a copy of the slides on the webinar recordings page of our website, and I will drop a link to that in the chat momentarily. Your lines are muted to prevent background noise, so please remain on mute so we don't have a lot of extra background noise, but please feel free to enter any questions that you have in the Q&A box or the chat. After the webinar, a survey will automatically open in your internet browser. We do ask that you please complete that survey. It helps us to continue to improve our future events, and there's also a place where you can put in a recommendation for future education topics. And so with that, I'd like to welcome Dr. Mayers. He's a board-certified nephrologist and hypertension specialist, having completed fellowships at Johns Hopkins University, Dartmouth-Hitchcock, and most recently working in parallel with international leader in hypertension, Dr. George Bacris at the University of Chicago. When he's not caring for renal patients in Southeast Louisiana, Dr. Mayers stays busy partnering with Bayer to expand their existing kidney clinical platform for therapies to cover existing care gaps. He also enjoys spending time mentoring and upskilling the next generation of providers through teaching at LSU's Rural Family Medicine Residency Program. Dr. Mayers understands the critical nature of improving kidney care for Louisianans and is excited for the work he's able to do in partnership with the National Kidney Foundation of Louisiana, including the ongoing Rural Chronic Kidney Disease Dual Testing Project, focused on increasing chronic kidney disease dual testing for disadvantaged citizens in rural Louisiana parishes. So thank you so much, Dr. Mayers, for being here, and I'm going to hand it off to you.
Thank you. Let me get started here with slides. And all right, can we see this?
Yep.
All right, great. All right, guys, thank you so much for joining us today. Here's my disclosures. Here's briefly some of the objectives that we're going to have. Emphasize the importance of both eGFR and UACR testing, provide an overview of the CKD heat map. We'll spend a few minutes going over that in depth. Discuss and educate on the often underappreciated cardiovascular risk associated with decreased kidney function and increased albuminuria. And then lastly, briefly go over the new concept of a pillared approach to therapies in this disease state. So in order to get started, to make sure we level set for everybody, let's go over what the actual definition of chronic kidney disease is. It is defined as an eGFR less than 60 milliliters per minute, or albuminuria with a UACR greater than or equal to 30 milligrams per gram, or both decreased eGFR and increased albuminuria for greater than or equal to 3 months. What we see here is just a picture. This is a PAS stain illustrating the Kimmel-Wilson nodules. Okay. All right. Are we? Are we good to go?
Yes. My apologies. My Zoom crashed for a second, but I think we're okay.
Okay. I just wanted to make sure. All right. We'll go back here for 1 second. Everybody, these numbers are staggering. However, what's even more scary is that by 2060, we are estimating that the diabetes population in the United States is expected to almost double, with greater than 60 million Americans having diabetes. So definitely something that we need to be mindful of. And then lastly, this last point, patients with CKD associated with type 2 diabetes are at increased risk of cardiovascular events. And we're going to talk about that here over the next couple of slides. This slide really illustrates that Increased cardiovascular mortality is associated with both diabetes and with chronic kidney disease. But if a patient has both diabetes and chronic kidney disease, significantly increased risk of cardiovascular mortality is associated with this. However, it's not just cardiovascular mortality that they're at risk for. As they say, as the first bullet here says, 3 times greater risk of cardiovascular mortality in patients with CKD and type 2 diabetes. But they also have a 5 times greater risk of hospitalization due to heart failure and a 2 times greater risk of having an MI compared to patients that just have type 2 diabetes alone. Now, as a nephrologist, most of the time, patients are not coming in and asking me about their cardiovascular risk or about their cardiovascular disease. Their big concern is, hey, doc, am I going to end up on dialysis? And this slide really does a good job of illustrating that in older patients, patients greater than 65 years of age, they have an increased risk of cardiovascular death that's significantly higher than progressing to end-stage kidney disease. So even though that's one of their main concerns, it's very important that we understand how high of cardiovascular risk these patients have. And it's important that we address this. It's kind of oxymoronic, but oftentimes the patients that end up on dialysis are sometimes the lucky ones because they've lived longer and they've lived long enough to not pass away from a cardiovascular event. Now, how do we do in Louisiana here? This data is a little bit old, but I think it illustrates the point here that approximately 14,000 Louisiana residents have end-stage renal disease, meaning that they're having either they're requiring renal replacement therapy of some kind or having to require a transplant. And we can still see that almost even a couple years ago, back in 2018, that almost 2,500 patients a year were progressing to end-stage kidney disease, meaning that they needed to start some type of renal replacement therapy. Interestingly enough, I can tell you the data still supports this, that of that 2,500 patients, approximately 40% of them are, quote, crashing into dialysis, meaning that they're showing up at the doctor's office or they're showing up at the hospital needing emergent initiation of dialysis, really emphasizing the fact that we need to be doing a better job of identifying these patients early and getting them on therapies to hopefully decrease that risk. Especially for the clinicians on this call that are practicing in a rural or potentially underserved area, it's very important to emphasize that not only chronic kidney disease, but end-stage renal disease, meaning requiring the initiation of dialysis or some type of renal replacement therapy, is increased in certain patient populations, including African Americans, Native Americans, and Hispanic patients. So once again, very important that we take care of these patients and get them identified. All right, we're going to shift gears here for a second and talk a little bit about albuminuria. What do I mean by albuminuria? This is when we measure, we do a simple urine test on the patients and determine are they spilling albumin, which is a type of protein, into their urine. And this is the sign of ongoing kidney damage. If you look at the little cartoon on the left, this kind of just does a representation. In a healthy kidney, our kidneys do not spill protein. We should not have albuminuria detectable when we measure for this. However, in a damaged kidney, if, for example, somebody that has had long-standing diabetes, had long-standing blood pressure, this can cause damage to the kidney and to the filtering unit. And our filter in the kidney is made up of 3 things: endothelial cells, glomerular basement membrane, and then our epithelial or photocytes that help prevent us losing this albumin into our urine. When we measure for albumin, the test that we should be using is a UACR, or urine albumin to creatinine ratio. We'll be talking about this a little bit more over the next couple slides, but this is a simple random urine test which lets us measure and quantify how much or to what degree we're spilling urine. And we break it into 3 different categories here: A1, A2, A3, based on the severity: less than 30, 30 to 300, and greater than 300 milligrams per gram. When you see the terminology in the yellow and the red, A2 used to be what the term, we used to use the term microalbuminuria for this 30 to 300 range. And the A3, we used to use macroalbuminuria. One of the reasons this was changed to moderately increased and severely increased is that the microalbuminuria, it just often gave the impression that it was micro. It wasn't something to be worried about. But as you'll see on these next couple slides, these patients have significantly increased risk of having worsening kidney function, as well as having cardiovascular event. I think this cartoon representation does a very good job of showing why we want to be identifying these patients early. You can see here that it is oftentimes years where we see increasing albuminuria before we start to see a decrease in eGFR or a decrease in renal function. Meaning, if we are measuring both of these variables, eGFR and UACR, and we start to see increasing UACR, this is going to give us a significant amount of time to not only identify these patients, make sure they implement the appropriate lifestyle changes, make sure we get them on appropriate therapy to decrease this risk of having worsening renal disease. This is another great representation that I think is often underappreciated. Let's start on the right when we look at eGFR. Now, what do we mean by eGFR? It stands for estimated glomerular filtration rate. And the reason it says E or estimated is this is from a formula. What we do is we take the serum creatinine from any lab, metabolic panel that you get, a CMP, a BNP, or a renal panel. That serum creatinine level, based upon the patient's sex and their age, we put that into a formula, and it gives us estimated glomerular filtration rate, or lets us measure how good or bad the kidney's functioning. Up several years ago, both the ASN and the National Kidney Foundation recommended that there should be no race modifiers used in this, meaning that in the old days with our labs, we used to see African American and non-African American patients on that. We should not be doing that. We should just be using the non-African American patient calculations, what we should be using for everybody. But as you can see, you start to see an increased risk of cardiovascular mortality very early in this process. When our eGFR drops below 75, we start to see an increase in cardiovascular mortality. So very early in the progression of our chronic kidney disease, it's important we identify these patients. And if you look on the left here, when we look at UACR, when you start to see UACR get above 30, get into that microalbuminuria range with the old terminology and that increased range, we start to see a significant increase in cardiovascular mortality. However, I want you to move even just a little bit more to the left and look at this. When the UACR is greater than 10, we start to see an increased risk for cardiovascular mortality, emphasizing the point that healthy kidneys do not leak albuminuria, and it's important that we identify these patients. So all of this risk starts very, very early on in the disease process. Okay. If everybody's not familiar with the CKD heat map, they are going to be here in just a couple of minutes. This is going to be the one slide I spend the most amount of time on because I think this is the most important for us taking care of patients. So this is a very important and very handy tool for clinicians to not only accurately diagnose chronic kidney disease, but accurately stage the severity of the chronic kidney disease. I have a heat map in every room of my clinic, and it does several things. So we'll just kind of walk through this. One, it emphasizes the point that we need to be measuring both eGFR and UACR to accurately diagnose these patients. Keep in mind, eGFR measures kidney function, UACR, and the degree of albuminuria we have measures ongoing kidney damage. And by plotting the patient on here, when we have these two variables, using the eGFR on the left and albuminuria on the top, it allows us to risk stratify their risk of CKD progression. And it's very simple because you see the color scheme on the right here, that it allows us to stratify them into low, moderately increased, high, and very high risk of having CKD progression. The other thing that's new on some of the updated versions of this heat map is you see the number in each of the little boxes right there. What each of these numbers corresponds to the frequency or the number of times that patients should be tested with eGFR and UACR per year. If you see in the top left with patients that have no albuminuria and they have very good kidney function, obviously they're just recommending once a year annual test. However, as we move to the right, meaning we have worsening albuminuria, or we move from the top to the bottom with decreasing kidney function, those numbers increase, and we recommend testing and close following and more frequent labs. The other thing that's in here is we have screen when patients have normal renal function and no albuminuria. But when we notice to see they get to moderately increased or high or very high risk, the two different things that are in the boxes are treat and refer. Now, this is very important because it used to not say that. It used to just say treat, and then it also just would say refer when they had more advanced disease. The reason we've changed this is for several reasons. One, we want to battle clinical inertia. We know that when a guideline is updated, there's recent data that shows it takes almost 17 years for a guideline to be updated, for it to be incorporated and fully accepted into practice. So we don't want to wait that long to get these patients and make sure we change how we're treating and identifying these patients. It's also a call to action to everybody on this call. You know, the clinicians that are practicing in primary care and practicing in these rural, you know, environments. Often you guys are doing a great job in taking care of some very complicated patients. And oftentimes there can be delays, and it can often take several months for them to get in to see a subspecialist, including a nephrologist like myself. So that treat and refer is very important there. Last couple of points I want to make. Color scheme. You know, this is very handy when you're talking to the patients. When you show the patients where they line up on the heat map, regardless of their medical literacy, they can understand, right? If they've ever driven a car or they've ever watched Sesame Street or anything like that, they know green is go and good, and red is stop and bend. So it really can get them involved, and it's a very easy to teach the patients why we're measuring this and the importance. I also do a lot of teaching with the medical students and the house staff. It's very easy for them to grasp after just one sitting with this, to allow them to be able to talk to the patients as well. The other thing of making sure that the patients understand what's going on is just going to allow us to participate in shared decision making with them. And if they're more involved and they understand what's going on, that's going to help improve adherence to them taking the medication, the therapies we recommend. Last couple of points. You know, when a patient comes to see me, they're often significantly more advanced. They're normally in, you know, G3B or G4 range, you know, very decreased renal function. And what I tell the patients is, I cannot shift them up on this chart. I cannot take you from an eGFR of 30 and make your eGFR get back to 60. But one of the things we sure as heck can do nowadays is we can shift them from the right side of this chart to the left, meaning if they have significant albuminuria, by lifestyle changes and with the new therapies, which we'll touch on at the end of this, we can have significant improvement of decreasing their albuminuria, decreasing their cardiovascular risk, and decreasing their risk of CKD progression. It's very important on this next slide. I'll revisit this, but specifically in this A3 category, that greater than 300 milligrams per gram, we know that if we achieve a 30% reduction in UACR, this is associated with an approximate 20% reduction in CKD progression. So definitely very important. Last point on this, as I showed you on that previous slide, decreased eGFR, increasing albuminuria is associated with cardiovascular mortality. So though it's not a one-to-one, keep in mind these colors also can help illustrate to the patients that they are at increased cardiovascular risk, and really allows you to kind of talk about that heart-kidney connection. This is what I just made reference to. At the bottom of here, section 11.6 from the 2024 ADA guidelines. This just came out a couple months ago. This just illustrates that we should be targeting this 30% reduction in UACR. This has only been incorporated in the ADA guidelines since 2022, so still really early. So you guys can be kind of the tip of the spear here in making sure we educate the other clinicians and the patients that why we want to be targeting albuminuria reduction. Okay, I've been talking about UACR, urine albumin to creatinine ratio. This is a random urine test. It's very cheap and it's very easy. There are other different ways to measure albumin or measure protein in the urine. I'm going to go through this very briefly, and hopefully at the end of this, you'll understand why I'm recommending, and not just me, why all the guidelines recommend UACR testing. We'll go over the guidelines here in just a second. So if you look at the third one over here, 24-hour urine albumin, this was previously the gold standard and what we needed to do, meaning we needed to have 24-hour collection of a urine sample, and then we were able to quantify and measure the amount of albumin in that sample. However, it's cumbersome, It's not easy on the patients. The patients need to store the urine on either on ice or in the refrigerator. There's risk for over and under collection, and if it's abnormal, we often have to repeat this and ask them to do it again. So it's not the easiest on the patients. The other thing, if you go to the far right, using an albumin sensitive urine dipstick, this is often what's sometimes used in clinics. The problem with using just the urine dipstick is that almost 1/3 of patients in that very high albuminuria range are not identified appropriately by using this. The other thing is how concentrated the urine is can also affect if there's a false positive or false negative. Oftentimes, these patients are coming in fasting to get their labs, so this definitely can affect that. The other thing, accuracy often depends on how these dipsticks are stored, the manufacturer of the dipstick, and other kind of variables like that. Lastly, this is a qualitative test, not a quantitative test or a semi-quantitative test. These come up with trace 1+, 2+, but they do not give us those specific numbers that we're looking for to accurately plot the patients on the heat map. I'll point out this one here, the urine protein to creatinine ratio. This allows us to measure all the proteins in the urine, not just albumin. This is something that oftentimes nephrologists are looking for, just because there's certain guidelines and certain glomerular diseases that we recommend we treat to urine protein to creatinine ratio. But the reason the UACR is recommended over the urine protein to creatinine ratio is the urine protein to creatinine ratio is not a completely standardized test, unlike UACR. Meaning that if I get a UACR in Alaska one day, and then a couple weeks later I go down to Florida and I get another UACR, I can compare those and see if there's any changes. Unlike, you cannot do that with the urine protein to creatinine ratio. And we know that the UACR is what closely correlates with cardiovascular risk and CKD progression, specifically in type 2 diabetes. All right, moving on. This is not just me saying this. I'm not going to read all of these guidelines here for you. You can take a real quick look. But even the most recent iteration of this was the 2024 ADA guidelines that they are saying at least annually we should be checking both eGFR and UACR in patients with type 2 diabetes. And it's very consistent across all of these major guidelines. They do also emphasize if you have decreased or worsening kidney function, we should be checking this more frequently. All right. All that being said, why are we spending so much time talking about this? Well, now if you weren't as familiar with the cardiovascular risk with albuminuria, now you know. And now you can help take care of these patients. You can help educate your colleagues. And the reason I'm saying this is the clinicians that are acting as primary care physicians or taking care of these patients, there's a lot more PCPs available than there are nephrologists. And most of the PCPs are taking care of the patients when they're much earlier in this disease process, meaning you guys have the biggest opportunity to identify these patients early and to get them on appropriate therapy and change their disease course. Oftentimes, there's just not enough nephrologists, and oftentimes by the time they get to us, they have much more advanced chronic kidney disease. Why am I emphasizing this? Well, this came from the Louisiana Kidney Disease Prevention and Education Task Force from a couple of years ago. This is kind of going to just reinforce what we just talked about. The first message should be the importance of early referral. We want to make sure that we educate providers to review all the medications that they're on for possible use of NSAIDs, as well as making sure we screen for both hypertension and diabetes for early detection of chronic kidney disease. The old pattern of referring to a nephrologist was to wait until their eGFR dropped really low, sometimes below 30, oftentimes below 20. We just want to make sure we educate all the providers that nephrologists should start seeing patients when they're more in that CKD stage 3 range, and meaning that in order to identify these patients earlier, we need to be measuring albuminuria and UACR. It specifically does call out here urine protein to creatinine ratio. Hopefully, by me going over that previous slide, you can see why we prefer UACR over urine protein to creatinine ratio. And we're going to finish up this lecture here on the last few slides talking about this. We've been very fortunate here over the last 4 or 5 years to have significant new medications to slow the progression of chronic kidney disease and decrease cardiovascular risk in these patients, which we'll be going over here shortly. How do we do here in Louisiana? Well, we do better than some and we do worse than others. But the main point I want to call out here is even the states that are doing the best, still 40 to almost 50% of the patients are not getting appropriate UACR testing. And across the country, we know that 1 in 5, or only about 20% of patients, are accurately getting at least annual UACR and eGFR testing, meaning there's a lot of room for improvement. And by us doing this, we can have a very positive effect, not only on these patients, but the overall healthcare in the United States. All right. Last couple slides before we switch to treatment here. This gives us a little bit more in depth. Those numbers were from a few years ago. We are doing a better job of checking UACR now. Still not where we need to be. A lot of the surround sound and the recognition of how dangerous this CKD associated with type 2 diabetes is, and the newer therapies have really given us some surround sound to make us do a better job of doing this. But I don't think this will probably shock anybody here. We do a good job of checking eGFR, almost 95%. Why is this? Well, anytime we're seeing a patient, we're oftentimes getting a BNP or a CNP or a renal panel. But we're still lagging behind in UACR testing. And the importance of this UACR testing is, as I've pointed out, the increased cardiovascular risk. But in order to catch the early patients, the patients that have albuminuria, before we start to see a significant drop in eGFR, these are the patients who we can really have positive benefit on and allow them to get on therapy for a longer period of time. Why else do we need to be doing this? Well, we're measured in how good or bad we're doing this. So HEDIS, this is the Healthcare Effectiveness Data and Information Set. This is used by different medical plans, both Medicare, Medicaid, and commercial plans, to measure performance of how we're doing. And then lastly, if we are identifying these patients early, we can make sure that we're coding them properly, making sure patients understand the risk factors, understand that they have chronic kidney disease. And also we're identifying and showing these patients are as sick as they are. Oftentimes we're taking care of very complicated sick patients, and it's important for you as the clinician, as well as your overall healthcare systems, that we're documenting and coding them appropriately. In order to help with all of the things that we've been talking about, I wanted to call attention to a couple things. So both LabCorp and Quest with the help of the National Kidney Foundation, now offer kidney profiles, meaning you can order one kidney profile test here, and it'll include both the eGFR and the UACR to help simplify. The other thing, I know these are kind of small, the nice thing about it is when you get these results from LabCorp and Quest, you can see the patients are plotted on the heat map or something very similar to the heat map in order to help you accurately diagnose them and make sure they get on appropriate therapy. Okay, for the last couple minutes here, I'm going to switch over to talking about some of the treatment guidelines and talking about how we need to be targeting these patients with a aggressive pillared approach to care. So this is from the ADA guidelines, and this just kind of illustrates the concept that these patients are complicated and we need to be addressing multiple factors with them. Number one, this goes without saying, these patients have diabetes. We need to be targeting excellent glycemic control, meaning targeting a hemoglobin A1C less than 7%. The other column that we have right here, we know that these patients, specifically if they have more advanced chronic kidney disease, have more difficult to control blood pressure, and we need to be targeting aggressive blood pressure control, targeting at least less than 130/80 for our blood pressure targets in CKD patients, in diabetic patients, and in CKD and diabetes alone. The next column here talks about lipid management. These patients should all be on the background of a moderate to high intensity statin. We know that very tight lipid control has been associated with slowing the progression of chronic kidney disease, as long as the patients have good kidney function, meaning that tight lipid control is associated with slowing this down as long as the eGFRs greater than 45 milliliters per minute. So if we catch these patients early, this is another thing that not only allows us to decrease the cardiovascular risk, also allows us to decrease their risk of having worsening renal function. And then making sure these patients are on medications that have both a proven kidney and cardiovascular benefits. All right. So how do we do that? What are these medications, and what should be using? What should we be using? Well, we'll go back in time. In 2021, we had two landmark studies that came out, RENAL and IDNT. Both of these were looking at angiotensin receptor blockers, and did they have renal protective effects in patients with CKD and type 2 diabetes? They did. Respectively, they had a relative risk reduction of 16% and 20% when we compare RENAL and IDNT. And this looked at two different medications, losartan and irbesartan. However, you can see, despite this improvement and this decreased risk of CKD progression, you see in this triangle in this red, there's still significant residual risk for these patients. So I'm going to talk about the pillars of care here. So without a doubt, we know the fact that RAS inhibition, meaning being on the maximal dose of an ACE or an ARB, is what is ideal, and we know that that is shown to have renal protection. So RAS blockade or RAS inhibition is one of the first pillars. However, unfortunately, from about 2001 all the way to 2019, we had several different studies and different therapeutic options that we looked at, seeing would they have continual cardiorenal risk reduction. And unfortunately, none of these really panned out for us. So it's not that we weren't looking, it's just we didn't hit on the right combination of the right therapies. That changed in 2019 when the results of CREDENCE came out. CREDENCE is a trial that looked at canagliflozin, which is an SGLT2 inhibitor, plus being on the background of either an ACE or an ARB. And what we saw here is we saw a 30% relative risk reduction in risk of CKD progression in these patients. So we know now that let me finish there, and then I'll go to that next one. So we know now that ACEs and ARBs have been shown to have this benefit, and we know that after CREDENCE, we know that canagliflozin had these renal protective benefits. And this forest plot here just shows a meta-analysis that looked at multiple SGLT2 inhibitors, and you can see that all of these favored the use of SGLT2s for cardiorenal risk reduction. And Dr. Backrest is one of my mentors, and who worked on a lot of these trials that we're going over right now. Famously, here several years ago, in an article, he made the comment that SGLT2 inhibitors are cardiorenal risk reducing drugs, irrespective of glucose control. So we should not just be using these in these patients with poorly controlled diabetes, that regardless of their glycemic control, they can have positive benefits. All right, so that gives us two pillars here, RAS inhibition and the use of SGLT2 inhibitors, which leads us to, but if you go back here, let me go back. But if you can see, despite RAS and despite SGLT2, just like that previous chart, even though this risk may be a little bit smaller, there's still significant residual risk. So what do we need? We obviously still needed to continue. We were looking for other medications that could possibly help have these benefits. One of these is non-steroidal mineralocorticoid receptor antagonism. The medication we're talking about here is finerenone. This is different from the traditional MRAs that most people are familiar with, spironolactone and eplerenone. This is non-steroidal. You can see this actually has a dihydropyridine backbone compared to a steroidal backbone. But where did this data come from? Well, there was two landmark trials, the Fidelio DKD trial and the Figaro DKD trial, that looked at patients with CKD and type 2 diabetes. And this study was designed to be looked at together, where the patients had the two studies had reciprocal endpoints, meaning the primary endpoint on one was the secondary endpoint on another. And this was designed to be looked at. And what they looked at, they put patients on the background of RAS inhibition, but not just RAS inhibition. They had 4 to 16 weeks to up titrate this to get to the maximal tolerated dose. They were then randomized to receive finerenone or placebo. If the patients were on SGLT2s, they were not excluded from this, though only a small percentage of the patients were on SGLT2 inhibitors, just because this trial started well before the results of the Credence trial. And what we saw is when we put both of these trials together, that we saw a 23% relative risk reduction in composite cardiovascular composite renal outcomes here. This was, as you can see, this sustained greater than or equal to 57% decrease in eGFR. This corresponds to the old measurement of the doubling of serum creatinine. So you saw that we did have a decrease in the doubling of serum creatinine, showing an improvement of reducing the risk of having having progression of our chronic kidney disease. And then also we did look at MACE-4 endpoints, so CV death, non-fatal MI, non-fatal stroke, or hospitalizations due to heart failure, and you saw a 14% relative risk reduction in that. Bringing us to, when we look at this, the totality of the fidelity pooled analysis of those two studies showed a 14% relative risk of the composite cardiovascular outcome, 22% risk reduction of hospitalization due to heart failure, 23% risk of the composite renal outcome, and then 20% reduction in the risk of dialysis. Now, because this is a mineralocorticoid receptor antagonist, we do know one of the things we needed to be mindful was to observe and watch the risk of hyperkalemia. As you can see, out of over 13,000 patients, only a little over 100 patients needed to be stopped due to hyperkalemia-related events with this, so a very small percentage of the patients. All right, so that takes us to our three pillars that we currently have: RAS inhibition, nonsteroidal MRAs, and SGLT2 inhibitors. All of these are on the background of making sure that patients are educated to make sure that they exercise, make sure that they lose weight, make sure they don't smoke. And we want good lipid, good glycemic, and good blood pressure control. However, we may have a new pillar that we anticipate to be added to this very well. The FLOW trial, which looked at semaglutide in patients with CKD and type 2 diabetes. This was a trial that was stopped early in October of 2023. We don't know the complete results that should be coming out shortly, but we do know from the data release that the top line data demonstrated a 24% reduction in the risk of kidney disease related events. So what does that mean? We're probably going to have an additional pillar that we're going to be looking at adding to this here, which we're still going to have to wait till the results of these come out until we can truly dive into the data and review the results. Last couple slides here, and then we'll open it up for questions. In 2022, the ADA and KDIGO came together because there is so much change going on, and this is such a rapidly evolving disease state, and we have so many new therapies, to come up with kind of a review and a holistic approach to improving cardiorenal outcomes in these patients. And this does another job of kind of illustrating what I've done on the previous several slides, that this is a very complicated disease process, and these patients need to be on multiple medications with multiple mechanisms of action. So if you look here at the top, this goes with what we looked in our pillars: lifestyle improvement, healthy diet, exercise, lose weight, stop smoking. If we look on this green, pathway here, this is our glycemic pathway that we illustrated previously. All of these patients, we should be targeting a hemoglobin A1C less than 7. Recommend that we use SGLT2s and metformin. If we need additional glycemic control, we can look at GLP-1s. We'll wait and see the results of FLOW, how this may potentially change this algorithm. If you look on the far right in the blue, this is our lipid management and cardiovascular risk modification. As I said, all these patients should be on a moderate to high intensity statin, and we want to be targeting at least LDL less than 100. But when they have good kidney function, if you can target an LDL less than 70, that's where it's associated with slowing the progression of chronic kidney disease. And this middle is our blood pressure and cardiorenal risk reduction. All of these patients should be on the background of RAS inhibition, meaning a maximal tolerated dose of an ACE or an ARB. And when I mean that, I mean a maximal tolerated dose, not just a tiny little tincture of 10 of lisinopril. It should be 40 of lisinopril if they can tolerate it. It shouldn't be 25 of losartan. It should be 100 of losartan. So we really should be starting them on max dose if they can tolerate it, or if they don't tolerate it initially, trying to up titrate the medications to get to the highest maximal dose that they can. And I'll close with this slide. So it's not all doom and gloom. I said there's going to be more and more people, developing diabetes in the United States, but hopefully you feel a little empowered after those last few slides. I know this is an exciting time to be a nephrologist and being able to take care of patients in this space. So let's go back in time to the 1980s. This was before we had ACEs and ARBs. This was before we had any of these therapies. And patients that had CKD and type 2 diabetes could expect an almost 10 milliliter per minute loss in kidney function. So let's put that in perspective. If they had moderate chronic kidney disease, meaning an eGFR of 40 or 50, these patients had a very high risk of progressing to end-stage kidney disease in just 4 or 5 years. That's terrifying. Now, as we started to learn about new medications, we discovered ACE inhibitors, and we discovered that non-dihydropyridine calcium channel blockers could also reduce albuminuria. We were able to improve this a little bit by getting the reduction in eGFR closer to 6 or 7 milliliters per minute. You can say that's not that much, but when you figure that often can add years to these patients progressing to end-stage kidney disease, and we're able to decrease cardiovascular risk, that's a very significant improvement. As we learn more and more about what glycemic targets we should be focusing on, what blood pressure targets we should be focusing on, and then, as I pointed out, renowned IDNT results came out, we were able to get this closer to 5 or 4 milliliters per minute reduction. And then, as we kind of talked about, we had unfortunately this approximate 20-year period of time where we weren't looking, we just didn't find these medications yet. But then in 2019 with Credence, with 2020 with dapagliflozin from the DAPA-CKD study, and then finerenone from the Fidelio and the Figaro trials, we were able to get more medications now that have proven cardiorenal risk reduction. And it's getting us closer to this 2 to 3 milliliters per minute decrease in eGFR. Now, it's not normal. Most patients after the age of about 35 or 40 lose about 1 milliliter per minute, but getting us closer to 2 or 3 is a heck of a lot better than we were doing 30 years ago with 10 to 12 milliliter per minute drop. So as we continue to get more and more therapies, we'll hopefully be able to do a better job of taking care of these patients. And with that, I will stop, and we will hopefully have a few minutes for questions, because I got to save a couple minutes for Ms. Torrey to talk about some of the initiatives the National Kidney Foundation is working on.
Great. If you do have any questions, please feel free to put them in the chat or the Q&A box.
I can't have done that good of a job. Somebody's got a question.
Okay, so I'm not seeing any questions come through just yet. So what I'll do is I will give Tori permission to talk if she wants to speak quickly, and then if any questions come in, we can answer those after.
Sounds good.
Great. Thank you, Danae. Thank you, John. Appreciate that presentation. And thank you to all of the providers that are currently on the call. To give you a little background about why we are giving you this information, we did a task force 2 years ago to look at kidney disease in Louisiana. And as was demonstrated on the slides, we saw that there was only 15% of Louisiana patients being dual tested for the UACR and the eGFR. We're like, okay, so what are we going to do about this? So we received a grant, the National Kidney Foundation of Louisiana, to team up with rural healthcare clinics and FQHCs around the state to do kidney health evaluation home test screenings to estimate the eGFR and UACR in patients 18 to 85 years old with a type 2 diabetes diagnosis who haven't had those tests in the past 12 months. So after this call, I'll work with Danae and the rest of you to talk more about that program and how we can get this directly to those patients that meet those criteria. With that in mind, because you did just have all this information and your patients will have access to this test and getting their results, last week in the mail, we sent educational materials for you and the clinicians in your clinics to help you understand the interventions that need to be taken at each step of chronic kidney disease. So realizing that these are all, as Dr. Mars mentioned, rapidly changing therapies, there is a guide in there for a program that the National Kidney Foundation developed called CKD Intercept, and that is specifically for primary care physicians. And then you also will receive the very important heat map that Dr. Mars talked about, that on one side is for professional education, and then the other side is for you to give to your patients so they understand where they need to be in that spectrum of care. So with that being said, as your patients are getting these tests and they're being processed through our partner, Everlywell, we have worked with them and will work with you and your EMR systems to seamlessly integrate into your patient's EHR the results of these tests. So that way there'll be no need to put in the data manually, and you'll be able to, as a clinician, really promptly access, review, analyze these lab results, and then facilitate quicker consultations and diagnoses with your patient and get them into the continuum of care that Dr. Mars had noticed. So really, this is about empowering you as physicians without having to do a heavy lift, without having to do any more expenditures. And in the long run, as Dr. Mars briefly touched on, that there is more of a financial incentive for you to more accurately code these patients based on the chronic disease state that they're in, whether it's in type 2 diabetes or CKD or ESRD. So we're really excited about the project, looking forward to working with you. Again, you should be receiving within the next 2 days that packet of both patient materials and clinician materials to better help you in your practices identify chronic kidney disease. And I will work with you individually to access your databases so we can get your patients these important tests, and we can work on identifying and stopping the progression of kidney disease within your patient population throughout the state. So looking forward to working with you, John. Thanks for doing the presentation today. Thank you so much for setting this up.
Yeah, thank you, Tori. All right, so any questions from the group?
I'll take any questions now just to make sure I get one.
Yes, we will have a recording of the webinar on our website. And I will repost that link here in the chat, and you'll also get an email. All right. So that question was, I don't know if you could see it. This person was late joining, and they just asked if the recording will be available. They loved the pieces that they heard. I just thank you for the information. All right, sounds like you did a good job. So any final comments before I wrap up?
No, I just want to say thanks, everybody. I know how busy everybody is, and I know this is lunchtime, and I know you guys are super busy. So thanks for taking a few minutes and spending the afternoon.
Great, awesome. Well, thank you so much for your presentation. As a reminder, everyone, when you exit, you should have a brief survey that'll open in your browser. So please do take that for us. It's just a few questions, but it does help make sure that we continue to improve our programs and give you the opportunity to give us any recommendations for future education as well. The recording will be up in the next couple of days. And if LRHA can be of any assistance, please don't hesitate to reach out to me. Thank you so much and have a great day.